Good evening. On behalf of the Student Academy of Doctors of Audiology, I would like to welcome you to today's Student Practice Management webinar, Change in Audiology. My name is Stephanie Chayeski, and I'm pleased to serve as today's course coordinator. I have just a few housekeeping reminders before we begin. If you have any technical challenges during the session, please use the chat feature to make me aware, and I will be glad to assist you. Please type your questions into the question queue, and they will be addressed by presenters at the end of the presentation. And finally, today's presentation is being recorded and will be available for online viewing this week. At this time, it is my pleasure to introduce the course moderator for this session, Anne-Marie Meisey, the SATA Communications Chair and a third-year AUD student at the University of North Carolina in Chapel Hill. Anne-Marie?
Thank you, Stephanie. On behalf of the SATA board, I am excited for the opportunity to welcome AUD students from programs across the country to this session on change in audiology. It is also my distinct pleasure to introduce today's course leader, Dr. Dawn Hyman. Dr. Dawn Hyman is a clinical audiologist. She's the owner of Advanced Audiology Consultants in Woodridge, Illinois. She also created Entree Audiology, which helps other audiology practice owners through regularly scheduled online audiology mastermind groups. She attained her clinical doctorate in audiology from the Pennsylvania College of Optometry School of Audiology. She obtained a Bachelor of Arts degree from the University of Pittsburgh and her Master's of Science in Audiology from Bloomsburg University of Pennsylvania. Dr. Hyman is a member of the Academy of Doctors of Audiology and the American Academy of Audiology. Dr. Dawn has given many lectures on various topics regarding hearing loss, hearing aids, psychosocial aspects of hearing loss, prevention of hearing loss, cochlear implants, auditory processing disorders, marketing and practice management to various private and public groups. Today, Dr. Dawn Hyman will be presenting to us the topic, Change in Audiology. Welcome.
Thank you for that nice intro. Thank you all for coming. I can't see any of you, but I hope that this is meaningful. And we are going to talk about something that is very poignant right now. As you know, many of you may or may not know, it was months ago that I was invited to present on this. And I did present on a similar topic at ADA in November. And I guess it was the assumption that I would give that similar talk this evening. However, as you know, things rapidly changed in our world. So we're going to address all of this because this is very timely. So I would like you to turn off all distractions, really focus, and try to think about what it is that I'm presenting. So tonight we're going to show you how you can be a part of the movement to take our profession to the next level. I truly believe that the way that we are going to come out of this and to innovate and to go into the next few decades is by empowering the young folks, those who are as students at the moment, those that are new grads, those that are the younger audiologists, because you can more easily embrace the technology and it's easier for you to change. So by the end of this presentation, I am hoping that you will have learned how to help implement change and to implement it in a way that it's well received and that it is also a lasting part of whatever practice setting you're in. And the biggest compliment to starting a change is the fact that others join in and that they continue to do it for a long time. So let's look at change, or let's say innovation. And in my mind, innovation happens with these 6 principles. Mission. What is your mission? You have a problem. You vulnerably admit that there's a problem. You then use your intelligence and your knowledge to try to tackle that problem. And then you organize what you're working with and then try to implement it. Experiment, be flexible. So let's start with the mission. Your mission is your why. If anyone has ever heard Simon Sinek speak, if you've ever read any of his books, or if you simply just want to look up TED Talks, Simon Sinek, Sinek. He talks about your why. He talks about how businesses that do well because their mission is bigger than the product they're selling. It is inherently based on helping others or doing something for a community. And when things become tough, it's your why that pulls you out of it. When we're struggling with even depression or burnout, it's our why that brings us through. We don't show up just because we show up. We show up because we care that people are having a difficult time with their hearing, with their balance, tinnitus. And so moving along this innovation pattern, once we know what our mission is, that we want to help others, then we need to scrutinize the daily routine of the clinic that we're in and find out, are there any problems? I truly believe that we can always learn, we can always innovate. There is always something to improve upon. And many of you probably have noticed, or maybe not, because I know you're students right now, and I feel bad for you because you're not in school at the moment. You're not in the clinics, and I hope that you're chatting a lot. But I can tell you, because I work with a lot of practice owners especially, that right now people are taking this pause on life because of the COVID-19 virus that has shut down a lot of our clinics. They're taking this time to innovate. They are taking the time to work on their practices, work on what they've always wanted to do, and also work on what maybe wasn't going so well. So when you feel like something's not quite right, you start looking at how it's being done. Sometimes it's just there are 3 clinicians and they're all doing things differently. And sometimes things are successful and sometimes it's not. And you need to look at those procedures and say, okay, how is it that we're all coming up with different outcomes? Or let's look at infection control. How can we improve our infection control? Is it good enough? Was our protocol good enough for opening our doors again when our states say that it's okay? I have a feeling we're all going to say no. We need to improve our protocols. So when you admit that you think there's a problem, you have to get comfortable with being vulnerable and uncomfortable. Admitting to yourself, admitting to your staff, admitting to your colleagues that there's something wrong. And that's hard to do, especially if you're a student, especially if you are low on the totem pole, so to speak. And you're saying, excuse me, I'm not special, but I have a suggestion. I just wanted to say, and the only way to start this conversation is to just start it. But I do highly recommend that you do it in a nice way. You might find that there are people that have been doing this for over 20 years, 30 years, and they might not take too kindly to a young person saying, I think you're doing it wrong. Because you wouldn't want to say it like that, right? If anyone watches Young Sheldon on CBS, you would understand there are ways to go about telling somebody that they're wrong. And so because you're smart and because you're currently in different clinics, you see the way different offices are running, you are smart enough to know that maybe some change could be implemented. So you need to use your brains, you need to use your textbooks, the processes that you were taught. Now, people always say there's textbook examples, and then there's real world. So how do sometimes some clinics stray from textbook to what they're currently doing? And sometimes we need to re-examine that process. We need to do research. How can we make improvements on this? So let's say we're looking at speech and noise testing. lately there's been a lot of chatter about that. How can we do it differently? How can we do it more quickly? How can we do it more efficiently? Are we doing it at all? Are we going to do it under headphones, insert phones, in sound field? We need to pull together all of the articles from before, from now. We need to ask others what they're currently doing. In the clinic that you're in, look at what materials they currently have. Do they have the hearing and noise test? Do they have the quick SIN? Do they have the BKB SIN? Why would you use one over another? You need to put together a good compilation of information before you can change this process. And while you're doing that, you can then start to dream, let's say, or brainstorm, or have a meeting where you're leading and you're saying, okay, here's the information I found. How can we do this? If we started doing speech and noise testing, because we're not doing it right now, do we do it before and after fitting someone with hearing aids? And if we do it afterwards, how are we going to take that information and use it? Will it be helpful for educating the patient? Will it be helpful in finding those that need to be referred for a cochlear implant evaluation? And the only way to really start this innovation is to really dig deep and to admit we don't know that what we're doing is perfect. So why not research it and find out what others are doing? So now that you have your why, you have your problem, you were vulnerable, you admitted that you think things need to change, you're using your intellect, now we need to organize this all. This can be the hard part. This is why sometimes change doesn't happen, because it's really hard to go from I have an idea to let's implement it. Really hard. So we need to create systems, standard operating procedures, writing things down. If anybody has ever heard the story of McDonald's, let's say, it started out that this place was making milkshakes. And then they found that people loved their milkshakes. So then the question was, how do we duplicate this? How do we replicate it? How do we make milkshakes just like they do? How do we use a machine and make duplicates of that machine so that whenever someone goes to this place called McDonald's, that they get a milkshake that's identical to the one that everyone loves? So let's go back to speech and noise testing or infection control. If we were to improve our speech and noise testing, what will the process look like? How do we, if there are 3 clinicians, let's say in the clinic, how do we ensure that everyone is doing the process the same way so that you have the same outcome? If infection control is your question right now, how do we safely open the doors so that not only are our clinicians safe, but also our support staff and especially the patient? How do we create this atmosphere of, number 1, we know what we're doing. Number 2, we're doing it for the right reasons. And number 3, it's efficient. So we have to ask ourselves, do we have the necessary tools? Do we have the right speech and noise tests? Do we have it connected to the audiometer correctly? Has anyone tested it? Is it working? Do we know what levels to present? If we don't have speakers in sound field, how do we get it? Or for infection control, do we have the proper PPEs? Have we researched, is a normal mask going to be enough? Do we need a mask with a filter for all procedures or just some? Do we need one of those clear hood shields? Do the patients need them? Do we need to have gloves? Do we need hand sanitizer? Should we have people washing hands? How are we going to disinfect hearing aids? How are we going to go about where we write all of this down so that when the first patient comes in, Are we following proper procedure, and will we do it the same way every time? We need to role play this. We need to find out, okay, let's pretend, okay, you're the patient today. Let's practice and go through the steps and go, oops, didn't think about that one. And we got to write down what went wrong so that when we start over again, that we don't miss that important step. Does this keep in line with our mission? Our mission, remember, is to help people, not to be a pain in their keister. We want them to have a magical experience. I worked at Disney World. We'll get to that. But we want everyone to feel as though they're being taken care of, and we're doing this in a proper manner because we are smart, we're educated, and we have a procedure that works. And then once we get through all that, we're feeling pretty satisfied, then we got to go back through again and ask ourselves, what are we missing? Because we missed something. There's something that we didn't think through. Do you remember being in like the 5th grade and having to write out the procedures on how you make a peanut butter and jelly sandwich? Like everybody forgot that you're supposed to open up the bag first and take out the bread. You were just like, okay, so you put peanut butter on the bread. And you have to make sure that you're not assuming anything. So now that we've gotten through all of these steps, we're now at this last one where we have to be flexible with our experimentation. Even with, let's say we think we've got it down pat, and then a patient or two come in and there are things that we didn't think of. Something comes up. So this is my friend Shandace Jeep, and she is in Colorado. And she has a friend who created this prototype for the masks because she found that when you put the mask on, someone with hearing loss can't hear very well, but now they can't see you. So looking at PPEs, let's say, she found that yes, we need to wear masks, but does everyone need to wear a mask that covers our lips? Can we have some masks that are different? What does it look like to the patient? If they're wearing a clear mask, it will be helpful for them. Do we need to do this for every patient? Let's say it's someone with normal hearing that's just coming in for routine wax cleaning. Do we need to wear this particular mask? Let's say that we get all these masks and they hurt. We might need to make some adjustments, or we find that they fog. We have to figure out, what are we going to do? How can we make this better so that it works for us and the patient? And can we start advertising this? Once you have started a new program, a new protocol, you've changed things. Is it good enough that you can tell the world? What we don't want is this. We don't want the terrifying scene from E.T. where Elliot is so worried and scared about E.T. because this is what being in quarantine looks like. This is what it looks like when everybody puts PPEs on, and it's terrifying, especially if you see little kids. We need to think about what we're doing and making certain that it is for the right reasons and that it is not a scary effect. So like I said, I did work for Walt Disney World, and my staff and I all read the book Be Our Guest. It was an assignment that we had. We also kind of visited Disney, and we were walking around making certain that we were cued into what they are doing. And I'm very interested, and I'm sure a lot of you are too. What would Disney do in a COVID-19 epidemic? You know they're working on improving things. I hear they're painting the castle. You know that they're working on policies and procedures to keep people safe and keeping their distance. They're probably installing hand sanitizers everywhere. For our clinics, we need to make certain that everything is patient-centered. They say that even if someone had a bad experience, if as they leave, everyone was concerned about them and asked them how they're doing and told them have a wonderful day, we'll see you on a different day. If it was a great experience at the end, that patient will report that they had a better experience than someone who had everything go perfectly and everyone was kind of blah. We already know that with our population, there are a lot of fears in just making an appointment. 80% of all people with a hearing loss do not do something about it, or they don't want to. And making that appointment is very scary. Coming into that first appointment is very scary. So with all of this and with any change that we make, we want to make sure that we are following our mission. And that mission involves ensuring that when someone has a problem, that we answer their problem. We need to solve their problem of, okay, I'm having difficulties hearing. We test their hearing and their hearing is normal. What are we going to do? Do we say, yep, it's good enough. Looks like you have normal hearing. Good job. No. So this is a slide that I had in November when I was talking about threats and opportunities in the audiology world. And some of this seems laughable. Like, honestly, I thought October 2020 was the worst thing ever. I had no idea that we were going to be in this predicament of honestly feeling like the world stopped. Our clinic closed a month ago. And I don't know when we're going to open again. Now we're doing curbside clean-in checks. I have people who've lost hearing aids and we're looking into how we can have them replaced. We're doing our best. People are doing battery pickups. Hearing aids are still breaking. I'm trying to fix them or send them in for repair, but people aren't coming in our doors. Now, the threats that are on the left here haven't changed. We still need to think about and change when it comes to online hearing aid sales coming in. And they're starting to become stronger because if people can't come into our clinics, they're going to sway to the easier route. That's if, honestly, if people really want to get hearing aids right now. The second thing would be third-party administrators. However, I feel like, now, as you may or may not know, third-party administrators are basically working with insurance companies to try to provide a benefit for the insured. And as we all know, they are basically the middleman for hearing aids between the consumer and us. And I have heard that 2 different third-party administrators are now going direct, or I'm sorry, the insurance companies are now going direct to the audiologists in 2 different states just this month, and they dropped the third-party administrator, which that's a huge win for us. But it's something that we have to think about. So if third-party administrators are there and they're changing the prices and our reimbursement, we have to think about our billing. How about direct-to-consumer and retail stores? Will Bose start selling in Best Buy? And then the big concern of deregulation of hearing aids and even over-the-counter products. How are things changing? So the opportunities for us are huge, however, because if you've ever heard this, I will say it again for you, people don't like to buy widgets. They like to buy from other people. There's always that relationship there. Even if you're buying a pair of shoes or sneakers, if there's a story with it, you're more likely to want to purchase it. That human interaction goes so far. So if we have the opportunity to tell our story, to put it on our websites, to talk to our patients, we win right there. Online hearing aid sales cannot do that like we can because we can provide that human experience. We have the opportunity to do counseling before and after this hearing aid sale, if we're just talking about hearing aids. We have the opportunity to listen, to dig in deep, hear their concerns, create a plan for them, create a prognosis, do the testing, Once they're fit with what's appropriate, then our counseling really starts to begin, where we're guiding them along. We are helping them to hear their best and give them realistic expectations. The online people cannot speak to that. They can't say, well, you know, we did speech and noise testing, and this is what is realistic for you. But you know what? I have some strategies for you. And I have a remote control possibly. Or we're going to talk about closed captioning. This is where our education really kicks in. This is where they have nothing on us. It's all us. We have the ability to provide positive reinforcement. We have the ability to say, you know what, I'm so proud of you. Look at what you've done. Look how far you've come. And they're still fumbling with putting the hearing aids on, but sometimes you just need to hear that. They're like, really? I'm like, yeah, remember you were so worried that you wouldn't know the difference between the right one and the left one. And look at you now. You know the difference and you're struggling a little bit to put on, but I just saw you do it 5 times and I'm proud of you. We get to do realer measurements. We get to actually touch a patient. Even if we're all gowned up, we have the ability to look in their ears, to clean out earwax, to find out, is it more than just an assumed sensorineural hearing loss? We have the ability to make proper referrals. We have the ability to know that what we're doing is validated, verified, and that we're making a difference. And we can make adjustments based on what we find. They cannot. Our appointments can be service oriented, meaning that we can create communication assessments as opposed to a hearing aid evaluation. We can talk about how our services will help them to have a happier life and a better quality of life. In our clinics, we can actually monitor quality assurance. We can say, okay, here's our mission, just like we said before, what I was talking about, is everything that we are doing in line with our mission, our vision, our why? And if not, let's change it. If you're a retail store, you are driven by numbers. You are driven by a 1-800 number. You're driven by corporate, blah, blah, blah. In our clinics, though, if we have doctors of audiology, we have the ability to say, hey, let's remember what's important here. We care about the people, and we're going to change with the times because maybe we've strayed from what's really important. Great customer service will take us so much further than you would ever think. People pay extra money for Walt Disney World because of the great customer service. Let's think about if you go to a hotel. If it's Motel 8 and it costs $39 for the night, you're not going to expect much, are you? You might even expect to get a little couple bugs or something, right? If you go to a high-end hotel, though, you expect that you're going to pay more, but you also enjoy the customer service and the concierge that asks you, is there anything more we can do for you? Or the water that has cucumbers in it, or the free spin class or yoga, or the fact that it's super clean and there's, you know, a mint on your pillow, you know. If we provide great customer service, people value that. And when we make them feel special, they are willing to pay more for that. That inviting atmosphere goes with it. Our education enables us to be able to provide what people actually need. This is not about a widget. And all of this can be marketed. Think about it. All of our marketing needs to be regarding how we have that human touch, how we make a difference, how we have validation, how we are all about this person and helping them to solve their problems so they live a happier life. Up till very recently, most audiology marketing was about get a free pack of batteries, $500 off the hearing aids. Here are the features of the hearing aids. And we forgot about us. That's not going to happen anymore. At least not on my watch. No way. We are going to innovate and change, and you, as the young new coming audiologists, are going to help take us to that next level, because you're not afraid of being the expert. You're not afraid of showing what you know and showing it on a different platform than what most audiologists are used to. Now, when it comes to being an expert, there is a man named Chet Holmes who was on the Tony Robbins Business Mastery stage for a couple of days in 2008. And he had a business where he taught businesses on how to be the expert. Like, let's say I'm Empire Flooring. He would teach, and his whole company would come in, it was a multi-million-dollar company, would come in and assess and say, okay, here's what you need to do. You need to spend $1 to $3 million on conducting studies about how your carpeting does X, Y, and Z. And then you're going to write a white paper about it, about how these studies, all this money you spent, shows that you're the best. And every level of marketing, from your website to the sales pitch to everything, was about this white paper. And I listened to that and said, oh my gosh, we already have studies. We need to stop talking about the widgets and the free batteries and the free hearing screenings and talk about what we know about dementia and hearing loss, about balance disorders, about tinnitus. There have been studies for decades that have been created that are at our fingertips. And we need to change the consumer's mind. We need to let them know that if they're having a problem with their hearing or their balance or their tinnitus, that they need to think audiology. We need to rebrand all of this, and we need to make certain. Oh, I'm going to take my headphones off because I think they're dying. Can you still hear me? We need to make certain that what happens is, when someone is having a problem, that they know that we are the experts in the field of hearing and balance and tinnitus. So if on the left we think about what we've already reviewed about innovation, and we need to follow our mission, we need to find out if there's a problem, we need to be vulnerable, intelligent, we have to be organized, and then we have to experiment. Let's think about some ideas of how we can innovate in audiology right now. So in my mind, I think we need to change from being a product-centered model to a service model. And again, going into that whole process of, we're doing a communication assessment, we're doing a balance assessment, we're doing an auditory processing assessment. Because the end result, honestly, is our abilities to teach people about how their lives could be better. And part of that would be doing routine screenings that maybe we're not used to doing. Someone comes in because they're struggling to hear. We should also do a dementia screening. We've been told this, and we need to start doing it. And the dementia screening, just to start, would be because sometimes there's cognitive overload. Sometimes people aren't processing what they're, even though they have a hearing loss, there's something more to it. And we should be referring to the proper referral sources if we suspect that someone is struggling from cognitive decline. And a quick 5-minute screening not only helps that person, helps their family, but it also establishes us as a good referral source for this doctor or clinic that we're referring to. And we're looking at the whole person. Same with balance. If someone has a mild hearing loss, the statistic is that 30% of all people with a mild hearing loss will have a balance disorder. They're a falls risk. Why are we not just doing a quick, simple balance screening. We could do the Fukuda stepping test. We could do the Romberg test. We could do head shaking. And if we have the screen, if we create our own little screening tools, let's say, if we have it already in our office management system that we're checking off that we have done this screening and this screening and this screening, we can also have it in our reports already sort of pre-written and click, 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 where we're putting that into our report and then we're reporting on what we found. I think a primary doctor would be very interested in knowing that someone is a falls risk, referring them to the proper person to have further vestibular testing done, possibly sending them to physical therapy, having the family look at what does their living situation look like. Can we look at their home and make sure there aren't too many rugs? Are there handles? We don't want people to fall. And then along those same lines, we need to take that's the before, but also we need to expand upon our services. No longer are we the hearing aid girl, let's say. We need to make certain that we're providing oral rehab, good oral rehab. We're not just showing people how to open and close their battery doors and change their batteries. We're starting to talk about giving homework. We're giving them listening activities. We have it written out. We have a system for them that goes over a certain period of time to improve their abilities to hear with these new devices. Even if they've been wearing hearing aids for years and we put them in something that has a wider frequency range, let's say, they have to kind of relearn what the toilet sounds like. It's a little extra high pitched and tinny, let's say, or people's voices, or just the letter S. Auditory processing disorders are services that we can include in our clinics. And it doesn't have to just be for children, it can be for adults. And the more you learn about auditory processing disorders, the more you realize that it can be applied to even an adult who's wearing hearing aids. They're struggling to hear in background noise. Can you create therapy, coaching, some follow through that will help them, because you are the expert in this. And if you know a little bit about all of this or how to help someone, I can guarantee you, you know a heck of a lot more than their primary doctor or their adult children or even some speech pathologists. You are the person that could figure this out, think, is this a service I could do? Can I go through the checklist on the left and innovate? Can I add this to our clinic? Now let's look at balance. Can we start doing falls risk assessments? Can we start, if we haven't already, doing the Epley maneuver? Now, I know a lot of people say, you realize that there are not codes that will properly reimburse us for this. I'm not saying that we should only do what is reimbursable by Medicare or what's reimbursable by the basic insurance company. I'm saying we need to provide services. And if people have a need, they will pay if we have created a system that works, that is organized, and that we show that we are improving people's lives. They will come because we are the experts. And if we advertise this, they will come because we are the experts. So here's the fun part, kids. We're going to be branding our offices. If people haven't already, inside and outside, we need people to know via social media, our physician marketing, and even just inside the office, we need to make certain that we are presenting ourselves in the best light, in the light that we want to be seen. So branding, meaning that if it's imagery, it's image, and some people could say, well, isn't that just being egotistical and you just want to take pictures of yourself? That's not what I'm talking about. I'm talking about if you have a website and the website has certain imagery because you paid a website consulting firm to build your website, right? And it looks a certain way because that's the way they do it. And people come to your office and your office looks nothing like the website. The colors aren't even the same. Isn't that strange? And they just don't see this continuity. Your business cards even look different. Everything just doesn't seem to flow. If you were to create a new practice right now, let's think big. Let's say you buy somebody's practice that is still living in the 1970s. I have audiologists that have done this, especially through my masterminds. And they're, oh, and I understand that you are possibly looking at building a business plan that you're going to submit to ADA for a contest, right? So, okay, stay with me here. You want to dream big. You want to close your eyes and you want to dream about what does the perfect office look like to you? What does the furniture look like? What color are the walls? What do you want to exude? Is it a designer practice? Is it a super comfy practice? Are you going to plan on seeing a lot of, let's say, musicians? Will there be leather and cow print? Are you going to have guitars on the walls? Does your staff have tattoos? Or are you going to be very prim and proper? Everything is button down, square corners, pin tucked, high-end mirrors and glass and chandeliers. I want you to write down and think about what you want your office to be known for. What image do you want it to be? Because it's yours. If you buy a 1970s practice, or you just started at a practice that's, let's say, even an ENT office, and you're the only audiologist, and the last person just retired after 30 years, and you walk in, and this happened to me before, and you're like, oh my goodness, I can't believe what this place looks like. And you spend 2 weeks throwing out junk, old, musty books that you're sneezing over. And you think, what does this look like to the patients? And then after you've gone through and you cleaned it up and you moved things around and you painted some things and you made it actually clean, you wouldn't believe the response from people going, oh my goodness, is this the same place? Is that a new desk? And it's like, no, but you can see it, right? You want to make certain that then the website has that same character. You want the physicians to know that all of the processes and procedures and all of the services that you conduct are at a level of excellence. And your social media and all of your marketing needs to show whatever it is that you want them to see. Now, I found this image a few weeks ago, and I think it's so cool because when it comes to branding practices or just innovation and change, just with, let's say, a website or the flyers or the infographics that you send to physicians, your business cards, the font that you use and the colors that you use exude emotion. If you choose something just because, you might be giving off the wrong image, let's say. So when you're thinking big and you're writing your business plan or you're reinventing that old stinky office in the hospital and you're thinking, here's what I envision. Also look at the fonts, look at the colors. Just like the furniture, the carpeting, the paint color on the walls makes a difference. People will pay more for an office that is clean and the person is professional, and they will refer their friends and family, as would their doctors refer to that, over a place that is dirty, haphazard, and don't have proper systems in place. Your branding goes further than you think. So when it comes to social media, we really want our patients to be a part of the story. We want them to be a part of our mission, and we want them to know that we love them, because the best type of marketing is word of mouth marketing. We want them to spread the word. We want them to love on us as much as we love on them. If you've ever been on Instagram and you've ever followed a celebrity, it's pretty cool when you get to see what they're doing, isn't it? Like, you already know they're in a movie that you like, or, you know, they have a cute haircut or who knows what. But when you get to see the insider and you're like, oh my gosh, look at, she's making pizza. How fun is that? They are becoming even more of a likable celebrity to us because they give us a window into their world. Social media enables us to do that. Social media is a long marathon type of marketing. It is not a sprint. It is not a one time I put up one thing and I made $20,000. No way. And a lot of seasoned audiologists are disappointed because they're used to 10 years ago or prior where they could send out a 5,000 piece direct mail piece and they could get 20 appointments out of it. And they think that social media is working the same way. It's just a different beast. Social media marketing is a lot like Google, and it is considered shotgun marketing. It is just kind of spraying the information and casting it over a vast, wide area. A lot like a billboard on a highway. People don't drive to your billboard to go see it. They happen to be driving down the highway, they're trying to get to the airport, and oh, there's the billboard. And you're lucky if they spend 2 seconds looking at it, and you're even luckier if they remember that they saw it. That's what happens on social media. People are there for a different purpose. They're driving by, and for a moment, you might get them to pause. And then later on, you hope that they'll remember that they saw something about an audiologist. But it digs deeper. Social media helps people to learn about you, learn about the practice, learn the inside culture. Like, people know I love my chalkboards in our office. They also know I love, and if you can't see it on the side there, but it says our mission. And it says that we're all about warm hugs and candy. And I can't give warm hugs right now, which just kills me. We're all about cookies and we're about coffee. And from what I understand, we have to take that away, and it breaks my heart. But when people look at our website and then they come into the office, or even better, if I've been doing videos and they got to watch the videos, they understand what's involved. They know who they're going to meet. And then it could be a teacher from my child's school who knows somebody who knew somebody that had a problem hearing. Guess who they're referring them to? And I never even talked to that teacher about the fact that I am an audiologist. They just happen to follow me or be a friend of mine on Facebook, and then somehow it went viral. I truly hope that this webinar helps you, because I know that you as a student are our future. And I hope that I was able to show you how you can be a part of this movement of taking our profession to the next level. I hope that you learned how you can be a part of implementing change, and that you want this to be well received. And you make a big difference in where we're going in this future. And as we start to reopen our clinics, and as we had to pause, and a lot of people are working on their policies and procedures and learning what they can so they can add more services, that's the wave of the future. Audiologists are aware of the fact that hearing aids might not be a big part of our future. but our services can be. And all of this that we learned as students and those things that we keep continuing to learn or seeking out more, like tinnitus retraining therapy, they can't take the tinnitus from us. Same with balance. Physical therapy's been trying for years. We can refer to them, but we should still be the diagnosticians, honestly. I want you to be empowered by this, and I want you to reach out to me if you have any questions. So therefore, we can definitely, if you would like, open up the floor to questions.
Wonderful. Thank you so much, Dr. Hyman, for that informative presentation. We do have a few questions in the queue, and I'm going to start with one that's related to when we think about services, changing services and expanding services. There seems to be a big piece missing on the continuum of care that is really related to hearing loss prevention. And do you have thoughts on how somebody who's entering the profession of audiology might parlay that into part of their business model?
Absolutely. That's a great question. And you're right. I didn't touch on that. When it comes to hearing loss prevention, I think dentists have done it very well. Where they, and this is where Think Audiology, I think, is moving along too, but we need to allow our community. And when you're doing community marketing and you're saying, okay, and when you write your business plan and it asks, how do you plan on marketing? What do you plan on doing? One of the biggest ways to become known in your community, let's say, would be to give the presentations, volunteer to go into the schools and teach about hearing loss prevention. You can also reach out to Michael Santucci, who created and owns Sensophonics. And he has great ideas about how you can do like industry night, let's say, for bands. So apparently, let's say I own a bar and it has bands on the weekends and things like that. And I have waitresses and barbacks and bartenders and all of that. Monday nights are the night that those people who were working all weekend long, maybe even starting with Thursday, they take Monday nights off. These bars are closed, but they want to get together and hang out with their friends. So one thing that you can do is find a bar that or nightclub or something that will allow you to invite a band, let's say, to or a lineup of bands, and you do industry night where you're going to have a table set up and you volunteer to take ear mold impressions for those people who work in this noisy situation. It could be the waitresses. You're going to make them musicians plugs basically, and it's sponsored by you. You can choose to charge a cover or not. You can say, nope, we're covering it. We're paying for the band and first drinks are on us, let's say. But if you want to be known for hearing loss prevention with the younger crowd, you can do that. Have tables and earplugs that you're giving away at parades, and there's like, let's say, Wednesday night in the summer concert series. I have found through my own trial and error that you tend to give away a lot of free stuff and you might not see the return. But it is definitely a marketing plan to create, and it's definitely something to talk to Michael Santucci about. When it comes to industries, there are audiologists who do hearing screenings for large corporate industries, and they help them to follow OSHA standards. So that is another piece of it as well. And then you can also reach out to gun clubs. People are shooting enthusiasts and they have target shooting and all of that. And in different pockets of the country, it is more and less popular. So if it's very popular and you can have, where let's say it's a night that the club members are going to be there, you can offer to come in and take everyone's ear mold impressions. Same with bands that are in, let's say, the church industry. A lot of these newer progressive churches have large bands that are on the payroll, And a lot of them come to me, and there's been times where I go to them and they either come one at a time, or I go to the church and I take ear mold impressions of, let's say, 30 band members all at once. And it's good to let them know, because they're having custom monitors made. It's good for them to know that they need to protect their hearing. You could take it one step further and offer to have the earplugs. You say, can I sponsor it in the back of the church for when the congregation comes for church services and that loud band is playing, there are earplugs for them, and it's you that sponsored it. Did that answer your question?
That is fantastic. Yes, thank you for all those. Those are really great ideas.
Oh, great.
Thank you. The next question is a specific. We have a couple of questions that are specific to certain protocols. The first of which is, how do you feel the best way to assess vertigo and Meniere's disease is? Do you have a certain protocol that you follow?
So for vertigo and Meniere's, you kind of want to differential diagnose. So Meniere's disease, with Meniere's, let's say, and specifically, I default to the ENT to make that decision, and it depends on the equipment that you have. And I can tell you that I went to school over 20 years ago, and protocols have changed. And I did set up a vestibular program when I was in my CFY year, but there are certain patterns that you see. History is huge with Meniere's disease. So I want you to have a strong history. Ask them, if someone is saying, I've had vertigo, and you say, your first question is, what happened the first time? When was it? How long did the vertigo last? Was it minutes, hours, weeks? Was it spontaneous, or was there movement involved? Tell me what happened. If they say it lasted for days to a week, and they had a roaring effect, and suddenly their hearing changed and the vertigo came on and there was vomiting and all of that, and their hearing changed just in one side, I can pretty much guarantee that that is Meniere's disease. If it's positional vertigo, they will say it came on when I rolled over or I sat up really fast. There are certain questions that you want to ask, and where to find the best answer. And if you want to have a business that is regarding vestibular, I would highly recommend that you take Richard Ganz's course. He has varying levels, and he is exceptional at this and teaching it. But you need a team approach on this for sure. And in order to truly diagnose, like when I was in graduate school, we would have done, when I was at Hershey Medical Center for my graduate placement, I would have done a complete hearing test and then go into doing an ECOG and the ABR. And then we would take them to the next room. And at the time, that's how old I am, we would do an ENG, because VNG didn't exist yet. And we would try to look at all the subtests and listen to the history and figure out what it is. Sometimes with Meniere's, it can take years to decide, is it Meniere's or not.
Thank you. That's very helpful. As we think about change in audiology and the way that services are delivered, obviously there's been a lot of talk lately about telehealth and delivering services that way. What are some of the things that you might be considering, like in your own practice, in terms of moving maybe towards telehealth in the future that you personally would not have considered, 2 months ago?
Right. That's a great question. I mean, I didn't even talk about that today. Telehealth, I think, is amazing. I was so scared to do it before. And now, especially, I have Counselor, and I'm a huge fan of Brian Urban. And with like the moment that we found out that we're probably shutting down our clinics within the day, within this week, Brian said, that's it. I'm giving telehealth for free. And I had the opportunity to get uncomfortable and try it with patients because suddenly it didn't feel safe to have people in the clinic. And yet I needed to follow up on them. They were in demo hearing aids where they'd just been fit. And I found it's fantastic. Like some patients, they take like a half an hour just to leave your office. With telehealth, you can be there and go, okay, I gotta go, bye-bye, click, and it just shuts off. So it's great for efficiency, but it's wonderful because it's different than a phone call. If they have a hearing loss, you can see them. I have not done any fittings with or made hearing aid adjustments with the telehealth, but I'm learning. And I think that is another exciting feature where we can do remote programming. There are so many great ways that we could use telehealth, including, and again, the dental industry. I go to that a lot. They have like Facebook ads, let's say, that where they'll say, call us for a free consultation for, let's say, Invisalign or for a dental implant or something like that. And it'll be a free 15-minute telehealth conversation where they look at the person's mouth, they talk to them and things like that. And then you move forward. It's different than doing a free hearing screening where we can just say, we can give you a 15-minute consultation. We listen to their concerns, find out whether or not maybe they should come in or not. And it could be a tinnitus screening. It could be, anything. But I think that that would be a very good tool where we're not blocking a long period of time in our schedule for someone who maybe just might be kicking the tires, let's say. They just had a quick couple questions, or sometimes they just wanted to meet you first and they go, okay, now I'm ready. I'm going to make the full appointment. So I think telehealth is fabulous, and I am using it right now, especially those that have they have appointments for new evals, but I have had to reschedule them twice now. And I at least I haven't tested their hearing yet, but I was at least able to talk to them on telehealth and go through their history with them. And some people are also doing this with the auditory processing evaluations, talking to the parents first without the child involved before they come, but it is a face-to-face conversation and it is scheduled at a different time. So it's more private and the child isn't listening to mom talk about, their concerns about the child, because that's kind of hard for the child to hear the parents say that they're concerned about them,
Mm-hmm.
right?
Excellent point. Well, thank you. I think that's going to definitely be something where there's going to be a lot of interest that's retained even after the current crisis
Yes.
on all sides. So thank you for that. Another question in the queue. I've got this one and then one to follow. So I do respect your time and I thank you for being so generous with it. This one is, when marketing your business more toward diagnostic services, how would you balance advertisements to also compete with other hearing aid businesses in the same community, even with a focus that's more on the diagnostic side?
Personally, I don't care what my competition is doing. I truly believe you have to have your blinders on and you do what's right for you. And then you'll find out that they're copying you. But that's their problem, not yours. I really think that if you are showing that you are the best and you're talking about your diagnostics, when you talk about diagnostics, you're talking about what you're doing for someone. And I really, listen, I have a lot of funny analogies, but honestly, if I was an auto repair shop, I don't think it would be appropriate for them to tell me about all of the different tools that they have and how they can lift up my car and they have this special thing to take the tires off and they can get in there and they use all these big words and stuff that I really don't care. What I care about is that they say, you have a broken car, we can fix it. And I go, cool. But if they want to tell me about their 15-point check and what I get for $39, even better. But I think we need to tell people in our marketing about how we can make their lives better. And don't talk about all of the tympanometry and all these little widgety like words that doesn't make a difference to the consumer because they don't know what that means. They just want to trust that you know what you're doing.
Great point. Thank you. Thank you for that answer. And then the final question is really related to, some of the discussion around this valuing services over the widget and how that's translated to other professionals in the community. So do you have any recommendations for how um, a, a newly formed practice might communicate and build up some referral sources, both incoming and outgoing, with physicians and other providers?
I think it really, and there's a book called What the Doctor Orders. Howard Mans wrote it, and he actually interviewed doctors and asked them about people who've marketed to them, about how to, market to physicians. And it really comes down to establishing relationships. If I say, hey, I have a friend I'm going to refer you to, it comes through it's such a stronger thing than, well, I think there's an audiologist in the strip mall down the street, um, and it's not easy to establish relationships. So the primary care physicians, the MDs, dentists, and even psychologists for years have been referring to each other because they know this person is this subspecialist and this one is this and this is this, and they actually have met them. I believe that one thing that you can do, and every region is different, honestly. Like where I am in the Chicago area, most primary doctors have been eaten up by some kind of conglomerate. They're not referring. They have their own audiologists in-house, which is kind of frustrating, but that's a whole nother story. In Utopia, or if I was in a certain network, let's say, or I worked for the hospital, I would say the number one way to market the services that I do is by having a lunch and learn that's continuing ed that's sponsored by, let's say, the hospital system, and talking about the comorbidities of hearing loss, or talking about how hearing can make your patients happier, talking about dementia and hearing loss. But I really think that with anything we do, if we can teach it, if we can get up and tell stories and talk about, well, there was this person and this is what happened and this is what I did for them. And then there was this person and this is what happened. This is how I helped them. Where you're their guide, someone had a problem and you solved it for them. You are going to establish better referrals, but even more so if then those doctors come up to you and say, hey, that was great, blah, 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 but consider how you can somehow meet the doctors, sending them information, but you definitely want to somehow establish a relationship if you can. The smaller the town, the easier it will be.
That
It's
makes
a hard nut to crack. It really is.
That makes sense. Thank you. And thank you for all of your insight. We're actually out of time for today's session, but if people have additional questions, I invite you to send them to info@audiologist.org, and I will be glad to forward those on to Dr. Hyman. If you have friends or colleagues who were unable to attend tonight's webinar, please let them know that the session has been recorded. We will send a link out to attendees after the recording is posted. And if you need more information about future SATA practice management webinars or to register for those, please visit audiologist.org/students. Thank you again, everyone, and have a fantastic evening.
Thank you. You too, Stephanie.